While we wait, if the teachers and colleagues don't have any questions yet, then
Yes, I invite Dr. Lan from Bach Mai Hospital. Dr. Lan Thien has a lingering question for the Japanese professor regarding lung transplantation for patients with interstitial lung disease. For patients with idiopathic pulmonary fibrosis, lung transplantation is clearly effective. However, for patients with pulmonary fibrosis due to autoimmune diseases, I would like to ask what the experience or outcome of lung transplantation in Japan is for those cases. Secondly, when patients have such autoimmune diseases, there are many complications from using immunosuppressants. This makes lung transplantation difficult. And secondly, when a new lung is transplanted, does the underlying autoimmune disease cause the new lung to develop interstitial pneumonia again? C. So I don't have the cases of the transplant, so the transplant, but so after transparent, so many in administrated, some transparent doctors say so it is not growing, they're not growing the interstimonia, so and if in the treatment is difficult, so transport is one of the choice, I think.
yes, I would also like to ask the doctor. Because both reports from Dr. Trang and Dr. Ney mention the very heavy task of MDA5. So I also want to know if in clinical practice, Ney uses the triple therapy as well as adding tofacitinib or baricitinib for the treatment of MDA5. In your clinical practice, what treatment we use for MDA5 rapid progressive icteruses? So in the rapid case of MD5 intersection pneumonia, so an hydroglucid and 1000 mg pulse and IVCY 750 mg. Intraven and Tactin is administered in usual clinical. Have you add to JAK inhibitor? I didn't do that. So some cases here, some cases was effective, so in China study. So is effective. Report. Yes, for everyone following, he said he uses the triple therapy mentioned by Dr. Trang, but he himself has not used the inhibitor yet. In return, he uses rituximab in cases that do not respond to this triple therapy. Hello. I would like to ask Professor Yoshiro, for example, I have a CTD-ILD patient currently on stable treatment with. I have a patient with CTD-ILD. I think I need to turn on the headphones. I have a patient with CTD-ILD being stably treated with low-dose steroids and MMF. And then the patient had an acute exacerbation. After ruling out causes such as infections, I treated them with corticosteroids and cyclophosphamide. My question is, after treating with cyclophosphamide during this episode, do I need to maintain it for the next 6 to 12 months, for the next 6 months for the patient? And if I continue maintenance for another 6 months, but about 3 months later the patient has another acute exacerbation, do I use it again? Thank you very much. So in the acute phase, we should have rapid therapy, rapid effective therapy. So, we need to rapid effective drugs, such as, corticosteroids. So for stabilizing the disease, in Japan, Teion picospin is added to that. For treatment. And after that, we can stabilize. So, I have the border. Is. I want to use. So. Antibody disease such as MD5-4. Antia syndrome, and some kind of antibodies elevated, so that causes the disease or interstitial pneumonia to reduce. So, the antibody is effective, it is considered. Is effective, so. Was biotologist. You see a number of patients have infection after. Yes. So, but in that condition, we find it difficult to assess the infection, so the CRP is high, lung shadow is developing. Is it due to the disease, and the condition is not stable, or is it an infection? So we need to monitor for. I just asked Dr. Kian if we can measure the ACE enzyme in Hanoi to diagnose sarcoidosis, because this is the first time a case has been diagnosed. Thanks to the lung lesions, thanks to eye lesions, and thanks to the quantification of the ACE enzyme, I would also like to share that Ho Chi Minh City has started to measure it, so colleagues interested can access a diagnosis that is very difficult, as Dr. Kian mentioned. Since we only have 2 minutes left, I would like to ask permission to conclude this session. In this first interstitial lung disease session, we had 3 very excellent presentations. The first report covers a disease similar to interstitial lung disease, which is sarcoidosis. Last year, Dr. Kian spoke on diagnosis, and to briefly reiterate, this is a difficult disease to diagnose, primarily encountered in lung patients. There may be various types of lesions, either lymph nodes or interstitial lesions. And when we approach this using the international guidelines, the I-2021, as well as the Ministry of Health guidelines, we can reach a diagnosis. In today's session, Dr. Kian emphasized that regarding treatment, not all patients require it. Treatment is fundamentally based on corticosteroids, and in some severe, high-risk cases, corticosteroids and methotrexate may be used. In the second presentation, Dr. Thu Trang emphasized that interstitial lung disease in Asians has characteristics that are more common than in white populations. The phenotype is different, so sometimes diagnosis and treatment must differ, such as screening for autoimmune antibodies more broadly, especially if there are clinical and imaging suggestions. Besides that, we don't have any RCTs regarding treatment, so we often have to rely on guidelines like the Japanese ones, which Mr. Song himself didn't criticize, but are practices in Japan, and Dr. Trang successfully treated that case using a triple regimen. However, one point Dr. Trang mentioned is that in clinical practice, infection is very important, so we must be extremely careful. And finally, Mr. Yone's presentation provided an overview of how to use immunosuppressive drugs as well as monitoring methods, allowing us a comprehensive review of these treatments. So, through this seminar, we see that interstitial lung disease was not common in the past, but is more common now, and we are diagnosing and treating it better. Like Dr. Trang said, many times in the past we just called it pneumonia and kept overusing antibiotics. Now, by naming it correctly and treating it correctly, we improve the prognosis for the patient, and in doing so, we are helping them. We would like to thank all three speakers for delivering excellent presentations. Thank you to Ms. Fuang for chairing and allowing us to speak from beginning to end, and thank you to everyone for attending until this time. Thank you, everyone. Image.